Hello, everyone. Welcome and thank you so much for joining us this evening. I would like to express my gratitude to SAEM at large, as well as the leadership from the Academy of Diversity and Inclusion in Emergency Medicine, the Equity and Inclusion Committee, as well as the Pediatric Emergency Medicine Interest Group. All whose support has made this webinar tonight very possible. And I would love to give a big thank you so much to our panelists tonight. Your efforts, your time, and the work you're doing is very much appreciated. I look forward to an insightful and engaging conversation tonight. For those of you who do not know me, my name is Tatenda Bupepi, and I'm a fourth-year medical student at St. James School of Medicine, and I have a strong interest in emergency medicine. A little bit about myself: I was born in Harare, Zimbabwe, and my family moved to the U.S. when I was 6 years old to pursue better opportunities. I am extremely passionate about providing equitable care to underserved communities, which drives my work in healthcare, research, and advocacy. It's my honor tonight to be a host for this important discussion that we're having on providing pediatric care in the emergency room. For tonight's webinar, we do not have any disclosures to be made. So let's go ahead and meet our panelists. I'm honored to introduce our distinguished panelists for tonight's webinar. Each have made significant contributions to their communities by providing equitable care to migrant children and their families. Their dedication to bridging gaps in healthcare access and addressing disparities in migrant populations is truly commendable. I am deeply grateful for their commitment to this important work that they do. So without further ado, I would like to introduce Dr. Owen. She is an assistant professor of emergency medicine at the University of Pennsylvania. She also helps run Puntos de la Salud, I hope I'm pronouncing that correct, which is a 501c3 non-profit organization providing comprehensive healthcare and social services to uninsured Spanish speakers in Philadelphia. She is also involved in healthcare of migrants. She has spent over 15 years providing care, both domestically and internationally, to migrant communities. We also have Dr. Jimenez, who is a fourth-year emergency medicine resident at New York Presbyterian Columbia and Cornell, and she is a U.S. veteran. She has experience as a hospital corpsman during Operation Iraqi Freedom and Operation Enduring Freedom, which has shaped her commitment to provide patient-centered care as well as addressing healthcare disparities. She's a Tillman Scholar. She's passionate about dismantling barriers to care, particularly for underserved and marginalized populations, including veterans, asylum seekers, and migrant communities. Dr. Jimenez has extensive caring for asylum-seeking patients as well as migrant patients, and is deeply committed to advocacy, health equity, social determinants of health, policy, and expanding access to quality care. We also have Dr. Cooper, who is a first-year resident at the University of Chicago Internal Medicine and Pediatric program. She serves as the co-founding board member for the Migrant Mobile Health Team. She earned her MD from the University of Illinois College of Medicine and got her bachelor's degree from the University of California, Berkeley, where she also was raised and born in Caracas, Venezuela. Before she went to medical school, she previously worked as a medical assistant and a pediatric behavioral therapist, as well as a neuropsychiatric research coordinator. Within the work she does at the Mobile Health Migrant Team, she has helped grow, mobilize, and structure the team during its inception and has supervised and participated in numerous street medicine runs, notably working with the Chicago Department of Public Health from within, where she has worked with affected shelters to help contain a measles outbreak last year. She also uses her native and medical interpretation Spanish language proficiency within residency, and also if time allows during her Chicago street medicine runs and her work at Clínica Novelas Racy shifts. We also have Kelly Ballman, who is a first-year medical student at the University of Illinois Chicago of Medicine. She also has worked with Dr. Cooper and the Mobile Migrant Health Team. She is part of the Research and Community Partners Lead for the Mobile Migrant Health Team. And Kelly has previously worked as a project manager in healthcare software and later on as a research coordinator with the All of Us research program. She received her Master's of Public Health and Biostatistics from the University of Illinois, Chicago. She's been volunteering with the Mobile Migrant Health Team since July of 2023 and previously worked to establish relationships with other free clinics in the city, community-based organizations, as well as key stakeholders in Chicago. Most recently, she helped establish the Mobile Migrant Health Team's Clinica Nouvelle RAC, which is a student-run clinic for mobile migrant patients. Lastly, we have Maida Palinati, who's a third-year medical student at Albany Medical College. She has a deep commitment to advocacy and global health. As a child of immigrants, she has dedicated her career to serving marginalized communities while working with refugee and immigrant families through organizations such as the San Damiano Refugee Partnership and Refugee Immigrant Support Services, MIS, which is known as RISE, and the Annunciation House. She has provided healthcare to undocumented workers, asylum seekers, and migrant families at the U.S. border, as well as in New York. MIDA has also advocated for Medicaid expansion for undocumented individuals and educated medical professionals for undocumented individuals on trauma-informed care for refugees and migrant patients. She remains dedicated to addressing healthcare inequities and supporting vulnerable populations. So I think it's important for clinicians to understand who are our migrant patients that we're serving in the emergency department as well as in the community. What are some of the common healthcare access challenges they face, and what are the legal, medical, and social and psychological considerations we have to take in mind when providing care? Migrant patients in the U.S. represent a vulnerable population with unique healthcare challenges. These children include refugees, asylum seekers, undocumented immigrants, and those in mixed status families. Many face significant barriers to healthcare access, including lack of insurance, language barriers, fear of deportation, and limited access to preventative and follow-up care. In the emergency department, clinicians are often the first and sometimes the only point of contact within the U.S. healthcare system for pediatric migrant patients. So providing trauma-informed, culturally competent care is crucial to addressing medical, psychological, and social needs while navigating the legal and policy barriers to care for migrant patients. Well, the goal for tonight's panel discussion is to explore the most important aspects of care that clinicians should know when treating pediatric migrant patients in the emergency department. Our goal is to highlight some of the key considerations that will help enhance the quality of care for this vulnerable population. The question for our panelists tonight would be, what are the most important things clinicians should know about the care of pediatric migrant patients coming into the emergency department? So at this time, I will turn it over to our panelists, starting with Maida.
Hi, everyone. Tatenda, thank you so much for all those introductions. I feel really honored to be here and to be taking part in such an important conversation, especially now. I think this education is really important just in terms of understanding who our patients are when they come to the clinic, when they come to the emergency department, and how we can best serve them. So I wanted to just start with a brief overview of who the population we're talking about is. So when we say international migrants, we are talking about anyone who has traveled from their home country to another home country. But when we're talking about forcibly displaced peoples, these are people who did not leave their homes by choice. And children actually make up greater than 1/3 of all forcibly displaced people internationally. You can see in this pie chart 50.2 million people of the total, which is greater than 30% of the people who have been forcibly displaced from their homes are kids. That is a pretty staggering number. So when we're talking about refugees, asylum seekers, migrants, a large proportion of who we're talking about is kids. 28.1 million of those people are internally displaced kiddos. So they are kids who left their homes due to violence or due to environmental disasters, but never actually left the home bounds of their country. And then 15.3 million of those kiddos are refugees. So they're people who have come to a second country and they've achieved refugee status, meaning that they have gone through the asylum process and have been kind of rewarded with benefits of being a refugee in the second country, or sometimes third or fourth country that they're living in. 2 million of those kiddos are currently seeking asylum. So these are people who are in asylum proceedings but haven't yet been granted that refugee status. And then just 1.7 million, which is a pretty sizable proportion of this, are refugees in Palestine. And, we recently saw with the eruption of this conflict in the Gaza Strip that a lot of kiddos are really being affected in terms of their health. And so how does this translate to like who we're going to see in our patient populations? In the United States, 1 out of every 4 kids has an immigrant parent, and 1 out of every 10 kids is a US citizen with a non-citizen parent. So we are dealing with a lot of kiddos who are immigrants, but also a lot of kiddos who come from immigrant families and deal with the traumas of coming from families who have been forcibly displaced, whether or not they have been themselves. And so I think it's really important to kind of know just contextually what these numbers are like, because statistically speaking, everyone who works in healthcare will encounter someone who belongs to this population in the future. And it's really important to know how to take care of these kiddos because we will be seeing them. I kind of wanted to just provide a little bit of context. I don't know what happened to the first image there, but this is a CDC graph of the impact of adverse childhood experiences on health outcomes. So we know as healthcare clinicians that the more adverse childhood experiences someone has endured, the more likely it is that they're going to be suffering from chronic conditions, both mental and physical, into their adulthood. We know that toxic stress builds up in the body over time. We know that kiddos with 4 or more adverse childhood experiences displayed elevated levels of CRP more than 20 years into their adult lives. And so we know that the accumulation of trauma really impacts our patients. And so when we're talking about kids and kids who have migrated and or who come from families of people who have migrated, it's really important to consider all the really unique traumas that they might be facing. So this photo, which is deeply saddening to me, is a photo of Alan Kurdi, who's a little boy who is 2 years old, who was washed up on the shore after drowning right in the sea right off of the shore of Turkey while he and his family were migrating and trying to seek safety from violence they'd faced in their home countries. And so I just point this out because when we're talking about this population in particular, these kiddos are so vulnerable because of a bunch of trauma that they have faced in many different circumstances to physical and mental health conditions that we might not consider occurring as frequently in other populations. And so I wanted to kind of highlight a survey that was done by UNICEF in 2018, which tried to really give voices to kiddos who had been displaced. And so they sent out an international survey to refugees and asylum seekers across the globe, and they had about 4,000 respondents, which is pretty sizable. And 38% of those respondents reported that they didn't receive any help from anyone, not family, not friends, not institutions during the migration process. 58% of respondents lost 1 or more years of school, and then 49% of respondents did not see a doctor when they needed it. And I wanted to point this out because there is a variety of trauma that comes from this journey, kind of as we've discussed, and it comes in many forms. And what that means is that these kids are not getting access to the things that we generally think that kids should have access to in order to thrive. This is school, this is healthcare, this is vaccines. And so when we talk about trauma and the impact of trauma on someone's health in this community, we can really kind of think about it in 3 different phases. So there's pre-migration displacement trauma. So whatever the inciting displacement incident was that caused a kiddo to have to leave their home initially. Then there's the trauma of migration. So the traumas along the way that families endure, which can be really scary, if not scarier sometimes than the violence that initially caused them to leave their homes. And then the third is post-migration trauma and acculturation trauma. And a lot of the things that we think about this community being more vulnerable towards really bridge all three categories. Things like family separation. Kiddos can be separated from family members early on during violent conflicts. They can be separated during migration journeys. I've met kiddos whose parents have passed on or had to be left behind during their migration journeys. And then once in the United States, for example, fear of deportation of their parents can be a real stressor, and that is another form of family separation. And so there's all sorts of different stressors that these kiddos are really vulnerable towards. And unfortunately, this leaves them in a really vulnerable position in the United States. So kiddos in this population are more vulnerable towards child labor, sexual assault, detention and incarceration, homelessness. We talk about malnutrition a lot. I think, especially in the migrating population, I've seen malnutrition and vitamin deficiency syndromes in kiddos much more frequently than I ever have seen in New York hospitals, things like that. And then infectious diseases, we think about our kiddos who are missing healthcare, who are missing years of healthcare, not receiving the vaccines that our kiddos who have healthcare routinely in the United States receive. And then all of that kind of leads to mental health and behavioral challenges. So these kiddos act out in school because they missed a year of school. And so now they're behind. And a lot of the times they're learning English amongst peers who already know English. And that can cause extra trauma. And then there's kind of this last one that I really want to point out, which is the trauma of just growing up too fast. I think a lot of really young kids are exposed to really hard traumas early on in their lives, and it causes them to kind of have a perspective that ordinarily kids might not have until they're a little bit older. And this doesn't only include witnessing traumatic events and experiencing adverse childhood experiences, but it also includes things like serving as translators, as the primary English speaker in your household for your parents when they come in to see a clinician. It includes things like knowing how to apply for SNAP at the age of 12. I've met refugee kiddos who are paying mortgage bills for their houses in their early high school years, taking care of little kids in their family and having to miss school to take care of little kids. So the things that this community faces in particular are very unique. And the intersection of all of these different struggles is really important to talk about when trying to figure out how we can best serve this community and best provide care in a way that allows them to thrive.
Thank you so much, Maida, for sharing your perspective. I greatly appreciate it. Next, we will hear from Dr. Owen.
Hi, thank you so much. I'm excited to be here. I am just going to kind of keep it brief and talk about a few of the main points that I think are helpful to remember in our work in the emergency department with certainly migrant children, but also immigrants of all ages and uninsured people in general. These are kind of some of the take-home points that I really try to impart to the learners that I work with. I think the most important is to ask yourself, is my discharge plan or my disposition plan safe and reasonable given this patient's insurance status? And we could broaden that out to be legal status or home situation. Basically, just taking that moment to stop and ask, is my plan safe and reasonable? I work in the emergency department and I also help run a nonprofit for providing healthcare to undocumented people. And one of the things that I see most frequently in that work is people who are seen in the ER, they have some kind of fracture that requires outpatient surgery, and they're discharged with a plan to see an orthopedic specialist in a couple of days to get surgery set up. And in most situations, if you are uninsured, that is not possible. And it's not a safe discharge plan because you're basically providing someone without a solution to the healthcare, like serious healthcare problem that they've come to you for. So I think this requires not only being familiar with how your electronic health record shows patients' insurance status, talking to patients about their insurance status and their access, and making sure that if they don't have outpatient access to specialists, medications, testing that are needed for next steps, that you've considered alternative options, like having a discussion with your consultant or colleagues about admitting the patient to get things done inpatient, which is often much more doable for someone without insurance, or having them stay in the ER to get further testing that is not going to be possible for them to do as an outpatient setting without insurance. So I think those are some really important questions to ask, and to kind of remind our colleagues as much as possible to kind of ask themselves these questions as well. I think the next key point would be to be familiar with what your local options are for healthcare and other kinds of social services for un and underinsured people in your area, regardless of their immigration status. So there's federally qualified health centers throughout the country that can provide healthcare and oftentimes specialist care as well to and medications to people regardless of their immigration status and ability to pay. But we need to know where these places are, what their capacity is, and be able to direct our patients to them. Other resources to know about are the private nonprofits in your local area that provide healthcare or other kinds of services and are accessible to patients. So for those of you who are students or residents, I think this is something that we can all really do together. That's like a fairly low-hanging fruit to make a difference, is collaborate to come up with a list of like, what are these resources in your area, and figure out how can it be something that is easily dropped in with a smart phrase to your discharge document, or on paper and easy to hand out, because I work at night and usually these needs come up so often at night when there's no social worker there to have this conversation, right? And so making sure that like we know what these resources are, but also having them be accessible kind of regardless of kind of time of day and situation. And then I think finally is making sure that you're familiar with what the process is that your patient will go through to receive financial assistance or social work care at your facility. So every hospital and health system does this differently in terms of kind of when people are asked for insurance, how social workers approach patients, and how they may or may not help patients apply for charity care or insurance. And I think this can be really scary for a lot of people who are uninsured, but especially migrants or people without legal status or with kind of questionable legal status. And honestly, currently in like the confusion over what policies are going to be in place for immigrants kind of going forward over the next couple of years, I think it's especially important. People are afraid to share information. They're afraid to share their documents, and everyone wants to, protect themselves and is a little bit unsure about kind of if healthcare can be a safe place for that. So I've definitely had patients who we've been trying to set up to get charity care to get things done, who kind of leave as soon as people start asking them for their address, proof of income from their boss, proof of having a bill with your name on it. And so I think as clinicians or people working in the healthcare space, we can tell them, don't be surprised that the next thing that's going to happen is that someone's going to approach you and ask for these documents while they're trying to help you get coverage or get care or get this and that resource. And so to give them that like awareness that's coming, and to remind them that this is information that we keep in the hospital that can't be shared and is not shared with the federal government. So I think those are, again, some of my kind of key points, and happy to answer questions in the chat or as we move on. So thank you so much for including me.
Thank you, Dr. Owen. We will now hear from Dr. Jimenez.
And thank you for SAEM for having me today. So as mentioned in my introduction, my name is Guadalupe. I am from New York City. I am a child of immigrants. I'll tell you about my experiences personally, and then also my experiences helping the migrant population, specifically children, and then what my learning points are, combining those two things from lived experiences and from what I see in this population. But before I do that, I'm going to share a link in the chat. This is the Advocacy Immigrant Toolkit that's on the SAEM website that was published last year. Like, this was published, and I think it's a good resource. So if anybody wants to access it, I think it's a good read, and it has a lot of helpful links. But as mentioned, and let me just make sure I'm keeping track of my time. As mentioned, my name is Guadalupe, and my parents are from Mexico. My parents came here to this country when they migrated to this country when my mom was 5 months pregnant with me. So all our lives, my childhood, we did indeed have the experience of being mindful of ICE and having those experiences of living in the shadows as a result of having this specific migratory status. While I didn't have that migratory status because I was born here, my parents did, and so did my siblings. There's certain things that are really impactful living in that way, and I would like to share that with you all today. Generally, so that's generally my lived experience. And nonetheless, I was like grateful for this country, and because I like received a lot of help from like the Catholic Church, the community, public schools in terms of food and assistance. I did end up joining the military and serving my country as a result of that in the Iraqi and Afghanistan war. So my experiences are mainly in terms of the migrant population and serving them were in Mexico, Ciudad Juarez, and then Texas. That's where I met Meta. And yeah, I served some of the shelters there with the Jesuit Refugee Services. And so we went there. I got to experience that struggle that these population had in trying to, at the time, go through CBP-1, which is the asylum seeker portal to try to get an appointment here and cross legally. So that was a big challenge for a lot of the children there because sometimes they faced that separation from parents where they were here, they were living with uncles and aunts in the shelter system at the border awaiting to cross. Also, once they did cross, I encountered them at the shelter systems there at the border, specifically El Paso, Texas. And so I got to witness firsthand, while the shelter system was amazing in terms of like the services they provide to the children, nonetheless, it is a shelter and it is lots of people in transit, unstable home, and then inevitably there's going to be their trauma associated with that. And there I learned and I saw witness firsthand like the resilience these children have and the things that we have to kind of keep in mind when dealing with this population of children specifically. I also worked St. Francis of Assisi, the migrant center here in New York City, and I work with the youth group and tutoring at a local convent here in New York City as well that has a lot of the population, the children here from all the way from first grade to high school to 12th grade. And I still see it firsthand, like now that they've transitioned from the border, how they are when they arrive and their adjustment. So all these things really factor into the population of children. And so what I wanted to focus on is the trauma-informed care. I know Meta spoke about it a little bit, but I think it's like really critical to recognize the level of trauma that these children experience from the time they leave, from the time of contemplating leaving their hometown, their home, and now no longer having a home, being in transit, being hungry, witnessing violence from people around them because like now they do not have homes, living outside at times, sleeping outside in the wet, like without protection and with uncertainty of their safety, arriving at, let's say, the border, for example, and not knowing what they're going to encounter because these are high risk areas, higher risk even at some points than their transit, depending on where they're staying. And then once they cross the border, then like will they achieve that? So there's lots of tension, there's lots of unknowns. So as you could imagine, in this transition from leaving their hometown or the preparation of leaving their home, their stable home, which now they're forced to migrate, whatever conditions they're currently suffering for their lives. So those stressors involved in that decision that their parents are making, that they have no choice over, whether they're young, whether they're toddlers, children, or teenagers, the turmoils involved with that. So as you can imagine, in what I described, the transition from leaving to crossing countries, arriving at the border, this is an experience that not many people face, especially children, and like that you would witness on a regular basis here in this country. I think that it could translate to, we could think about that and think about how children might present it to the emergency department. Children, normally, when they have concerns, they vocalize them. When they have pains, they cry, right? When they say something bothers them, they tell their moms or their dads, their parents, their loved ones. They could vocalize this, and that's what children normally do. That's a normal response. But in these environments, when they are making that transition, that is not feasible for them, right? Because they are going through so much trauma and so much violence, whatever is surrounding them, whatever is causing them to flee. Now they do not have a voice, right? They do not have that normal innate thing that tells them, I need to express myself. That is suppressed. So it's important when these patients arrive to our emergency departments that we have that knowledge that, hey, they're here it's possible that it's a little bit more than one might expect, right? Because once they have arrived to this country, I'll say we are living in the shadows. Like if we step outside for some reason, if we go to public areas, I have to make sure that like I know that we are at risk of losing our whole livelihood and going back to the area we're fleeing because we might be caught, because these are the risks. So if they're arriving to the emergency department, I would say that these patients are higher risk than the average population. So while they might seem to have a stomach bug, right? They might not have their moms or their dads or their parents or their caretakers had like they scrutinized the decision of going to a public space to now arrive to the emergency department. So I would say to like really probe a little more, talk a little bit more, investigate a little bit more before deciding on a disposition plan. So that is like the trauma-informed care. They're resilient and it's really challenging for them to express it could be, right? Not everybody's the same, but given their experiences, it might be a little bit more challenging to be able to vocalize their concerns or their maladies. Normal children obviously have that problem because their children are developing, but I think it's a little bit different for this population. Also validate their experiences if you are made aware of them. A lot of the times, I think like when I was with them, I witnessed some of the trauma that happened at the shelters, and it was like really shocking because like it was very traumatic, some of the things, something that happened there. And then they went back to playing as if nothing happened. Like at that time, just as an example, I pulled them all together and I said, this what you experienced was really hard. And I'm like, it is okay to be sad. So I like validated them and I told them that it's okay, which is something that they don't hear, right? Like I think the average children like hears that. But like when you're faced with all this trauma, it's not okay to be sad because like you don't want to call attention to yourself. It's not okay to cry. And a lot of the times it's like, don't cry, don't cry. That's the message that they receive because they are living in the shadows. And then when I said that to them in that instance, a few of them did start crying. We took a couple moments to cry, and then we took some deep breaths, and they went back to playing as if nothing happened. And so they are resilient because that's the nature of children. But then I think it's like more visible in this specific population. Other things, just kind of small points. If for some reason you are made aware that of their migratory status or their immigration status, please do not document that in the charts. It's not needed. If you're saying like if something needs to be documented, list whatever specifically needs to be documented. Like if they don't have insurance, okay, like you could say that if it's needed, but if it's not needed, please do not document. So do not ever document immigration status in the chart. If you do, or if you are made aware of that in the emergency department, and if you have time to chat, it would be good to have kind of some family planning in terms of designated parental roles in events these patients get separated, the pediatric population gets separated from their caretaker. And in New York State, all children under 19 have access to health care. That's specifically for this state. I'm not sure how it is outside its country. And then I think like Meta brought up a good point, which is the point that I wanted to make. These children grow up really fast and their lived experiences prior to arriving and after they arrive for many reasons. And so it's important that we don't contribute to that. Growing up too fast by using them as interpreters. They might be here at the same amount of time as their parents, and they might learn English quicker than their parents, that's okay. That's their children. They have plasticity in their brain is higher. But yeah, so yeah, just don't use them because you're contributing to their trauma and they don't know medical terms in that way. And so I think those are the biggest points that I want to make. Yeah, that's all. Thank you so much.
Thank you so much for sharing your experience. We'll now hear next from Kelly Bowman.
Thank you, Jacinda, and thank you to everyone who presented before me. I'm also presenting on behalf of Dr. Sarah Cooper, who's, as earlier mentioned, an intern at the University of Chicago. She had a last minute thing come up. She cannot make it tonight, but I'm happy to present on her behalf since we've worked together extensively with the Mobile Migrant Health Team. So just wanted to give a little bit of context about our organization. Just under 2 years ago, we started doing street-based health assessments for unhoused migrants living in and around police stations in Chicago, which were temporarily being used as kind of like holding areas for those waiting for shelter. We did thousands of street-based assessments with a large team of mostly student volunteers, as well as some very dedicated physicians. And just this past year, we've also stood up a free clinic out of a food pantry. So you can go to the next slide. I'll give just a brief timeline. So we've done a lot of the street medicine runs, as we call them. There was a lull period where there were no longer people living on the streets because city shelters had been established. But during that time, we did a lot of patient advocacy and accompaniment and a lot of advocacy, particularly for people with disabilities. We've done some vaccine support, and since June of this year, we started Clínica Nuevas Raíces, which is a clinic that primarily serves newly arrived migrants in Chicago, but also sees many different immigrant populations. So we always like to start with this video, which is a quick interview with one of our patients and their mother. It will highlight one of the main reasons for migration of children, which is to seek medical care in the US. I'll let it speak for itself and then continue on.
García y mi hijo se llama José Francisco Acosta Aldana. Venimos de Venezuela, de Coro, Estado Falcón. El viaje, nosotros teníamos tiempo ya diciendo que queríamos venir a Estados Unidos para poder ayudar con los estudios del niño, ya que en Venezuela no se podía hacer, porque una de las cosas, él le diagnosticaron neuropatía a predominio sensitivo a partir de los 7 años. Ya él me dijeron que con el desarrollo él se iba debilitando, o sea, ya iba perdiendo su forma de caminar, sus músculos, se iba poniendo flaco, hasta que iba a llegar a un término que no podía caminar. Bueno, nosotros en ese momento Venezuela no estaba tan, como te digo, o sea, no estaba en la crisis como está ahora. Como él no camina, mi esposo se lo amarraba. Nosotros nos paramos mucho tiempo, veíamos que la gente pasaba y nosotros nos quedábamos. Nos decíamos, vamos a llenarnos de fortaleza para seguir. Bueno, seguimos caminando, duramos 4 días en la selva. A él le dio fiebre, mi esposo ya tenía todo esto comido, con las sábanas que se amarraba conmigo. Mientras ellos se mojaban en el río, salían, dormíamos donde agarraban. Ya el último día no teníamos que comer. Andábamos con un grupo de familiares. Ellos nos dicen, nosotros te los vamos a dejar aquí. Bueno, mi esposo le dice, sí, váyanse. Nosotros, si no salimos hoy, saldremos mañana o cuando podamos seguimos avanzando. Cuando en la selva hay muchos muertos, personas que se caían, unas niñas que se cayeron. Él me dice, si a mí me pasa algo, tú sigue con los niños. Me deja aquí porque yo le decía, ¿cómo te dejo aquí? No podemos. Los niños vieron muertos. Muy feo, muy feo. O sea, un mejor futuro. Yo dejé mis 2 hijos mayores en Venezuela. Todavía trayendo los 2 pequeños. De la comandancia nos sacaron a un refugio a la Ogden. En la Ogden duramos, creo que eran 15 días, un mes, 24 días, creo. A mí me nombraron a la señora Mari. Ella me dice, pero ahí me ayudaron con la silla de ruedas, porque yo a él lo cargaba, era cargado como un niño, si bajaba a comer, si iba a salir, lo cargaba. Y me dice, yo le digo, yo necesito una silla de ruedas para mi esposo descanse y poder sacar al niño porque no lo saca. A los 2 días me llegó la silla de ruedas, se la regalaron en la ONU. Y me nombran una persona que ya la señora María había ayudado. Me nombran, hay una señora que ayuda mucho a los niños con discapacidad. Tienen el número, te lo voy a pasar. Y yo le digo, bueno, sí. Ha ayudado mucho, mucho, mucho la señora Mari. Como te digo, fue una bendición tanto como para mí, para mis hijos y a las muchas personas que también está ayudando. ¿La señora Mari trabaja para la ciudad de Chicago? No, ella trabaja porque ella es voluntaria y ayuda a los niños o sea, les nace de ella ayudar a los niños, no, pero ella no trabaja para la ciudad, o sea, creo que no trabaja en la ciudad. ¿Qué tipo de comida han ofrecido a tu hijo mientras han estado? Pan, y a veces que llevan comida que sí, pollo, tortillas, pero ahí la mayoría de veces uno come pan. Mucho pan blanco y a veces un pedazo de queso. Ajá, jamón y amarillo. Queso y jamón, o mortadela y jamón. Eso es lo que dan ahí en el refugio. O sea, eso es lo que nosotros queremos, lo único que queremos es trabajar. Trabajar y, bueno, yo quisiera ganar también el asilo para poder trabajar. Y honradamente trabajar y poder yo ganar mi dinero. No puedo, como me dice que le pidiéramos a la ciudad, no podemos pedirle porque nosotros queremos trabajar. Y con el trabajo nosotros podemos vivir. ¿Qué te gustaría ver en un futuro? Que ellos caminen, ¿Quieres caminar? ¿Es tu mayor deseo?
Thank you, Tatenda. So the video is very heavy, of course, but I think it really is a testament to the pre and during and post-migration trauma that a lot of families and children in particular have experienced, and also the ACEs that many of my co-panelists have mentioned so far. I would like to say the family is doing well. We've been in touch with them. They have established care. They're getting great care at a children's hospital in Chicago. And I believe the mom is working now. She has a work permit. That really was facilitated all by Senora Mary, who is one of our community partners who runs Bumblebee Agency. And they do a lot of care navigation for families with children with disabilities. I also want to bring this case report to light just to paint the picture even more. We met on a street run a 12-year-old child who had esophageal stenosis. He had ingested like a poisonous substance as a child, and the family had been traveling around South America looking for medical care for many years before they made it to the United States. They were in pretty critical condition when we saw them, and we immediately took them to the emergency department and had some of our volunteers accompany them. We're able to do the hospitalization, and they eventually got them connected again with another children's hospital in Chicago. And I really believe that if we had not seen this family on the street that day, that we would have found them in much, much worse condition. And I think this also highlights Guadalupe's point about families who are seeking medical care are often at a much higher acuity level if they are migrants. And I think that's really something to be aware of and watch out for as you're giving care. So I won't go into these takeaways too much because I think Dr. Owen already did a really good job of explaining them. But facilitating a bridge to primary care is really essential. Knowing your local FQHCs, your free clinics, and other resources, even things like GoodRx or Good Pill for low-cost medications are super, super helpful. A lot of food pantries are also giving out hygiene and medical supplies these days. So if you know of any of those resources in your community, definitely make sure that your patients are aware of them before they leave the emergency department. So yeah, this is just a few of those points. We can go on to the next slide. Another point I'm repeating, but utilizing interpreters and ensuring reading comprehension is really important. If you want to go to the next slide, we've really built out our own interpreting team. We have a number of student volunteers that are bilingual in Spanish and English or other languages. And we've utilized Coursera and other local courses in the Chicagoland area to bolster the medical interpreting skills of our volunteers. So making sure that the vocabulary and terminology is up to speed for all of our care in the clinic. And then, of course, I think Dr. Owen touched on this too, but attending to social needs and including social workers in the process is also very helpful. There are a lot of resources available to these patients, and it's going to depend on your city, your state, and of course, the changing legal landscape that we are all very heightened to right now. But social workers are really the best at knowing what resources are out there and making those connections. So if you have someone on your team who's able to provide resources and help people get enrolled in benefits that are available, this is very helpful. And I think on the next slide, we also mentioned schools are a great place for children to be during the day. And at school, children have access to food, shelter during the day if they're living unhoused, education, community. Oftentimes, there's also social work or mental health providers in schools too. So if kids are not enrolled in school, making sure that the social worker knows about that and can help families get connected is extremely important. So that's all I had to share. I think Dr. Cooper had one other thing to mention, which was if your emergency department is able to, getting a business WhatsApp account to communicate with families who maybe don't have cell phone plans is also really beneficial. And that's primarily how we've been communicating with our patients over the past couple of years. Thank you so much.
Thank you for sharing. We will now open the floor for questions. I see Emma Cortez has her hand raised.
Hi, everybody. Thanks so much for your talk. I'm an emergency medicine and family medicine physician, so I couldn't agree more with everything that everybody said. I am the director of a nonprofit organization called the Migrant Health Collaborative of South Jersey, and we focus mostly on migrant workers that come through New Jersey during the summer months specifically, and our goal is to try to bring medical care onto the farms themselves because, again, they're geographically isolated. My questions mostly would be for Kelly. Where does your team get their funding from?
That's a great question. So the first year we were mostly funded by community donations. We had a GoFundMe and we raised nearly $70,000 through the GoFundMe. This year we are funded by an NGO that's supporting us to hire 2 employees. One is a community health worker from our patient population, and the other will be likely one of our past volunteers who's bilingual. We are just really keeping our ears out for funding opportunities. So everyone on our team knows if we hear about anything, let each other know, and we apply to anything we can. There's a lot of support out there if you keep your ear open.
Who's the NGO?
Project Hope.
Thank you. And then just one more question. Do you guys, when you're doing the street medicine, do you have a way to prescribe medications or do you take medications with you?
Yes, so we came equipped with over-the-counter medications and supplies. And then what we would do is physicians that were on the runs with us would write scripts. We'd call them into the closest pharmacy. And then we'd usually send a volunteer the following day to go to the pharmacy, pick up all the prescriptions, pay for them, and then go back to the location, at that time was police stations, and deliver them to patients. So it was a second shift, if you will, to the street run, but that was the most effective way. And then we were able to use our funding to pay for all of the prescriptions.
That's great. I won't take up the whole time because I have a million other questions, but if it would be okay if I could email you, I would love to ask more.
I'll put our group email in the chat. So if I'm not available, you'll hear from somebody.
Thank you. And thank you to everybody for all the amazing work you're doing. I'm really very appreciative of it.
I want to just throw out there, GoodRx is so amazing. My patients are all in my clinic setting, all uninsured. And this is a key thing that we use. We do not have medications that we can give for patients. We cannot buy medications for them because we don't have the funding for that. But with GoodRx, almost anything you want is surprisingly affordable. And it can be really helpful even for people who have just not great insurance. Sometimes the meds are cheaper with GoodRx coupons than they are with people's insurance. And I think it's really helpful for us to think about, if you kind of look through GoodRx, you can find that different classes of, for example, antihypertensives that are like equally effective and reasonable are widely variable in their price. And even comparing like Rite Aid to CVS to Walmart, there can be like significant differences in price. So just super think that's useful for like clinic settings, but also for ER discharge. And another just thing about funding in general for this kind of work is that federal and state funding has always been challenging for this stuff. And it's like probably even harder now. And so thinking outside of the box and looking to nonprofits and foundations can be really helpful. I'm personally not a researcher, but I've learned over the years that like collecting some kind of data about the number of people you're seeing, what kinds of issues you're dealing with, like who's involved, even just really basic numbers can be really powerful in trying to like make the case for funding. So yeah, I dropped my email in the chat and I'm happy to answer other questions.
Thank you. Any additional questions or comments?
I actually have a brief one. You kind of alluded to this before about families making plans before there is separation. And we did a lot of education around this on the first Trump administration. And I'm just curious if anybody has any more updated versions of that or kind of how you most prefer to kind of counsel patients on kind of getting their paperwork in order, figuring out who the guardians would be if there is separation and what they would prefer to happen.
I can speak on that a little bit. We have worked with law groups, mostly the UIC Immigration and Human Rights Law Center, to do exactly those kinds of events. So they'll come out with sample paperwork and we'll bring bilingual volunteers and they'll do a little training on how to complete that paperwork. I think that's been really important for our families with kids with disabilities because separation is devastating for anyone, but it brings new challenges for those families. So being proactive is really important. So I'd reach out if you have like local legal support. There's plenty of like template materials that they probably know of and they can set something up.
I think also like the conversation is hard and it's going to be hard no matter what for families to talk about and to plan for. So I think anything you can do to just kind of help them feel like this is preparing for the worst case scenario and not preparing for something that is inevitable is really important, especially because when talking to kiddos, I've been a part of family conversations where the kids like really feel extra distress obviously from these conversations, but in a way that like impacts like their immediate functioning. And I think, just encouraging people to like think about this as a worst case scenario. It's like writing your will or preparing a MOLST form if you have an illness. It's kind of that same sort of counseling is a better way to approach it.
New York State specifically, and I'm not sure about New Jersey or wherever, but has this specific form, OCFS. It has like, and I'll put the link on that chat in the chat here. It's designation of person in parental relationship. So it's a document that parents could fill out prior to the separation to kind of detail out who would be in charge and what they're authorized to do. Like, for example, enroll in the schools, consent for school programs, enroll in healthcare plans, enroll in immunization. So I'm not sure if other states have something like this, but just want to throw it out there that something like this does exist and it's possible that it could exist in your state.
Great, thank you.
I have put in the group chat a Word document with compiled resources, just a list of some of the stuff that I found during my clinical experience useful. By all means, feel free to download it, check it out. There's stuff for both adults and children on there that I found very helpful from national organizations from like ASAP, SAE, as well as Academy of Pediatricians, American Academy of Pediatricians as well. So check it out when you get a chance. I want to thank everybody, especially our panelists, for joining us tonight. You guys did an amazing job. This was very informative, and I hope people learned something new today and can take back some new information to their institutions to continue providing care for our pediatric population in migrant communities. Take care and enjoy the rest of your evening.